48 hours on, 96 hours off, you're not home for 2 days. And spouses can complain about being single parents and raising kids on their own. And there's a lot of marital stress in the fire service due to the shift work. There's also a higher incidence of depression and PTSD. And we'll talk more about that. When we talk about stress, and in normal people, and of course, first responders aren't really normal. We're not normal, okay? But in normal people, there's kind of two kinds of stress. One is acute and one is chronic. Acute is when your fight or flight kicks in, and it's designed, you know, you have a release of adrenaline, cortisol, and that's designed to amp you up so that you can fight whatever you have to fight or run. But it takes a while for the body to return to normal, a couple of hours at least. Chronic stress would be, you know, kind of low-grade stress that's always there, you know, marital problems, financial problems, you know, problems with work-life balance, things like that. So what happens in firefighters in particular, it's a double whammy. So you have acute chronic stress, and we call it cumulative stress overload. This is a new term as of the Yellow Ribbon Report. And what it is you have a human being experiencing all the normal stuff that everybody does, and then you just pile all this stuff on top of the person. There's repeated exposures to trauma and everything that goes with it, you know, and on top of that, the lack of sleep and the shift work, and it's a recipe for some issues. So what are some of the reactions to stress that are common? Well, and this is where the awareness of stress and awareness of how you are reacting comes into play, because if you don't know what's going on with your mental state, you might try to numb it. And that's where a lot of the self-medication comes in. And there is a very high rate of alcohol use in the fire service and also in the EMS service, emergency medical services. And most firefighters deal with medical calls, but some agencies rely on we call them third-party EMS providers. That would be maybe a private company that runs EMS. But we deal with the medical. We're dispatched to all, you know, for example, suspected cardiacs, overdose, central wounds, whether stabbing or gunshot, and of course the traumatic vehicle incidents that we see. 1960, one of our stations is off of 1960 Northwest Harris, and there are, you know, incidents, you know, every week out there. I've even been on scene where the same drunk driver who caused one went on and caused a second one before coming to a stop. And so reactions to stress, the addictive behaviors can increase, reckless behavior. You don't really know what you're going through, so you numb it. And then eventually withdrawing from family, withdrawing from workers, you know, kind of shutting down. And that's where somebody can get into the suicidal ideation. Ideation means you're thinking about it. It doesn't differentiate if it's just a passing thought or if you're brooding about it for weeks. It just means you've thought about it. And then from ideation, behaviors might be making a plan or worse, making an attempt. So the #1 killer of fire and EMS personnel, is it structure fires? Is it MVI, floods, or homicide? The #1 killer is not structure fires. That's what most people think. The #1 killer is suicide. And this has been true since 2014. The #2 killer is cardiac, and #3 would be trauma. And many of the trauma deaths are caused by vehicle accidents, either on the way to the station to get on the truck if you're a volunteer, or driving the rig to an incident. So I want to pause a minute with this graph to just let it sit with you for a minute. So this is showing the deaths from 2010 to last year, and I'll update it with today's statistics. So this is showing the deaths by line of duty deaths, or LODDs, and suicides. And a suicide is only declared an LODD if it happens on duty or if it happens in the station, something like that. KD Fire Department had an LODD by suicide a couple of years ago and has had quite a time dealing with it. So the data on this chart, so the line of duty deaths come from the US Fire Administration, and they're confirmed. And for 2019, the official closing number was 62. So 62 line of duty deaths in 2019. The official suicide number in 2019 is 120 firefighters plus 20 additional third-party EMS, so actually 140. And I'm separating out the third-party EMS so that I can directly compare firefighters, not third-party paramedics, with the line of duty deaths. So that's just an explanation of that chart. So far in 2020, we have 75 confirmed LODDs that went up by 2 just the last 2 days. And 18 of those are COVID related. And so this year might be the first year since 2014 where line of duty deaths might surpass suicides. And it has nothing to do with the suicide problem getting better. It has everything to do with COVID taking more lives. And the number as of yesterday of confirmed suicides in firefighters in 2020 is 78, and third-party EMS is 21. So 99 fire EMS suicides so far this year, and we still have a ways to go. Just a quick note, I mentioned FBHA is the source of the suicide. That's the Firefighter Behavioral Health Alliance. And that is a 501c3 run by a retired firefighter, Jeff Dill. He was also on the Yellow Ribbon Report as an author. And NIOSH investigates all line of duty deaths, but there is no federal agency that investigates suicide. So Jeff has made it his life's work to try and track down and get a handle on the number. He thinks he's only getting about 40 to 50% of the data because as most people don't realize that that volunteer firefighters make up about 70% of the firefighters in the United States. And that is not going to be listed on a death certificate. Plus there is still such a stigma that many of the suicides are being labeled another COD, a cause of death. So let me switch gears and just talk about the statistics for the US population. And this is not first responders, this is all US citizens. So suicide is the 10th leading cause of death in the United States. It is the 2nd leading cause of death for ages 10 through 34. And I will point out that college students fit into that category. I'll talk more about that as far as most of the ages. It then drops to the 4th leading cause of death for ages 35 to 54. The 1st leading cause of death for all of those is unintentional injury or accident. And then after at age 35, then you have cancer and cardiac issues come up before the suicide number. So you see a bit of a change there. In 2017, so just in 1 year, out of US adults, about a little over 4% had suicidal thinking or ideation, 1.3% made a suicide plan, and 0.6 or less than 1% attempted. There are 30 attempts for every 1 death. Men have 4 to 1 fatalities to women, but women make 3 to 1 attempts, typically because women use less lethal means like poisoning, whereas men typically will use firearms or hanging. There is some unfortunate evidence that females in the fire service are dying by suicide, not by poison like other women, but by hanging or by gunshot by the men. And there's not enough data out there, but it is a little bit interesting and of course upsetting. Now, the last point on here, I'd like you to think about the lifetime rate. So this is over an entire lifetime of a person. The ideation is reported to be about 13.5%, planning almost 4%, and then attempts a little bit higher. Again, some of the attempts are impulsive. There wasn't a plan. So those are for the normal population. Now, this is just a picture. You can look this up on the CDC. This is just a graph showing you the statistics that I just mentioned for 2nd leading cause of death until age 35, and then it drops to 4th. So specific to the fire service, there was a study by Stanley, Hom, Hagen, and Joyner in 2015, which scared the fire service. It takes a couple of years for academic papers to make their way into the trade journals like Fire Chief and Fire Engineering. But I remember when this study started being talked about in the fire service, and it freaked everybody out. This was a nationwide study of over 1,000 current and retired firefighters. And of this study, that was a representative sample of the US, 46.8% had experienced suicidal ideation. Now that's compared with 13.5 of the normal US adult population. 19.2% had developed a plan, and a little over 15% had attempted suicide. So the 15% of attempts over a lifetime is what brought this issue, I think, to the forefront of the fire service's attention. And the culture in the fire service up until very recently, and we still have this culture persisting, it has been kind of the suck it up buttercup. You know, if you can't handle it, you know, go be a cop or something like that, as the joke goes. Now, getting into the why, first of all, the cumulative stress overload that we already talked about, but over the decades, there have been changes in the fire service. We're running a lot more medical calls. We're dealing with a lot more trauma. We're seeing things that we haven't really seen before. And we're also going on more suicide calls for the general population. I remember, I believe it was my first week actually on the truck as a probationary firefighter, and we made a scene right before dinner of a 14-year-old girl who hanging, a suicide attempt, and we ended up, you know, taking her to the hospital. We followed the ambulance to get our medic back, and we normally never find out what happened. But in that case, we found out because somebody knew somebody, and the girl lived, she was 14. She lived a couple of days at Texas Children, and then she passed away. If she had lived, she would have had horrific brain injury. So those are the kind of things that we see, and it does take a toll. So there's a theory, and I'm not going to spend a whole lot of time on the theory, but I'd like to focus on it just so I can talk a little bit about COVID and kind of where that fits in. So Thomas Joyner, I'd mentioned him on the previous paper. He is a suicidologist, and I didn't even know what that word was until I started studying this. So he runs a large lab that studies suicide out of Florida State. And Stanley and Hom, on the previous research in 2015 that I mentioned, are two of his doctoral students. In fact, they're postdocs who still work in the lab. And Kimberly Van Orden is also one of his doctoral students who's out in practice. So the construct is that there are two things that have to be present in order to have suicide ideation. One is perceived burdensomeness. And that means where you think that you're a burden to your family, you think that they'd be better off without you. I can imagine this type of thinking either in elderly people or in people who have terminal illnesses. And it's kind of like thinking in terms of blinders, where you honestly think that the world would be better off without you. So that's one thing. The other thing is thwarted belongingness. And this is where I think COVID comes into play. So the thwarted belongingness is where you don't feel like you fit in, you feel isolated from others. Hello, I think we're all feeling that. And you don't fit in, you're very isolated, and you're kind of shutting yourself down. So that's that construct, which I think is very common with COVID. Now, those constructs have to be present in order to have the ideation. To take ideation to an actual attempt, you have to have this thing called capability. Now, in normal people are kind of grossed out by imagining what suicide would be like. The problem with first responders is that we see so much of it, the gross factor is not really there. And so Joyner has hypothesized that for cops and firefighters and paramedics, that because we see so much of it, we overcome the capability pretty quickly. And so the leap from ideation into attempt is not as far as it would be for most people. And that's the scary part, because we can't undo the things that we've seen. But anyway, this is called the interpersonal theory. And I wanted to talk a little bit about that because of the COVID. And I think that's something that we all need to be mindful about. I know the media is talking about mental health and all of that, but it's this isolation that is really perhaps at the root. So I was attending a webinar on public policy about a month ago, and a couple of the universities up in the Northwest were talking about COVID and the impact on students and the isolation and the depression and the mental health. And I heard some statistics, so I went out and looked at a few things. And I haven't studied this as much as I've studied the fire statistics. Now, I've already mentioned that in ages 18 to 24, which I believe the majority of undergraduates might fall, that the CDC has said that suicide is the second leading cause of death. Well, in fact, from age 10 to 34, it's the second leading cause of death. So we know that college students, there is a huge risk factor there. Now, I found a study that was published in Depression and Anxiety in 2019, and it was a survey of 67,000 college students from over 100 institutions across the country. And it didn't differentiate between freshmen and seniors. I believe it was all undergraduates. And the statistics, I found them sobering. So 1 in 5 students have had thoughts of suicide. So that's what, 20% if I do my math correctly? You know, that's higher, that's way higher than the general population. 1 in 4 students reported having been diagnosed with a mental illness, whether it's depression, anxiety, bipolar, PTSD, you know, other illnesses. And there's also, I heard in the webinar, but I haven't found it in print yet, that 1 in 4 college students suffers anxiety that is so debilitating that it impacts studying and life balance and, you know, just general well-being. So I heard those statistics, and and I guess because I teach college students, it really had an impact on me. Some of the things, again, I'm not going to go through all the research. I don't know as much about it as I do firefighter things, but the stress, anxiety, and depression that we mentioned, there are a lot of researchers blaming social media. And research has shown that the likes that we get on Facebook, or, you know, whatever they're called, will release dopamine very similar to what crack cocaine does. So there is some science in the addiction to smartphones. And there's been some research out there that talks about smartphones as being so problematic. You know, the question is it the device itself, the smartphone, or is it the social media? And my students in Bauer, every year around career fair, they always ask me, "Oh, Dr. Fletcher, what's the best jobs? You know, what are the best jobs for business students?" And they always expect me to say something like, "Oh, supply chain or MIS or something." And I say, "Orthopedic surgeon." And they look at me like I have 2 heads and I'm crazy. And I said, "No, I'm serious. You know, you have an entire generation of people walking around with their heads down texting. You know, you're going to have deformities of C2, C3 spine, and you're going to have trigger finger and text neck and all of these types of things." They laugh, but there is some of that with the physiological aspects. I think the mental health or emotional health aspects are even worse than the physical. And so there are some, you know, significant issues there. However, there's been a little bit of research, actually not research yet, just some hypotheses that maybe college kids are doing better with coping with COVID than people my age, because they've grown up with having communication on their devices rather than face-to-face. So that might actually be a protective factor. I heard that very recently. I haven't seen any research that has tried to test that yet, but I think it would be really interesting. The third item here, access to mental health resources. Universities across the country have reported a huge increase in demand for mental health services on campuses over the past couple of years, and obviously even before COVID. And many of the universities, particularly public institutions with funding issues, have trouble meeting demand. And so access is definitely something. Battling the stigma, you know, being able to talk about it. In my supply chain class, in supply chain, you know, I wouldn't normally talk about mental health except when I get into some of my research to tell a story or if a student asks. But this semester I did something differently, and I went out on a limb and I made the first written paper to be about mental health and smartphones. And I gave the students a couple of readings, and I just wasn't sure what the result was going to be, but I've had really good feedback from the students that they enjoyed the outlet of being able to talk about it in their papers. And then of course we had a whole case discussion and class on it. And the other thing, you know, that came out of that is that I learned how passionate students feel about mental health. I didn't realize that. And so I think that's something I will continue that assignment next semester because I think it was really helpful. At least I learned a lot through it, and it will help me in teaching courses. And I already talked about, the a protective factor, potential protective factor of, being used to communicating through smartphones rather than talking. But other than that, if you take all of this stuff, it's compounded with the isolation and the Zoom fatigue and the eye strain with the COVID-19 isolation. So some of the risk factors for suicide: number 1, previous suicide attempt; number 2, history of suicide behavior in the family; exposure to suicide, death of another person. This would be very common for firefighters; depression, low self-esteem, anxiety disorders, history of trauma or abuse; sleep disorders, again, common in firefighters. I think it's also common in college students with inconsistent sleep hours, sleep hygiene, for example. Rumination is when you just keep thinking about something over and over, typically something negative. Substance abuse can result from these things. And then we all have stressful external situations, and we have different reactions to those things. Physical health problems, access to firearms. Protective factors, and again, go back to that interpersonal slide, imagine that Venn diagram. Social support, family support, connectedness is the single most protective factor. And this again is in adult population, not in first responders. And then one of the most important things is treating mental health exactly equal to physical health to help reduce the stigma. That's one of the things we're doing in my fire department. And trying to mitigate some of the other areas of stress. Again, we're going to be doing this in my fire department, bringing in courses on financial management, communication, how do you talk to your spouse after you get off a really bad shift, things like that. And then you see down at the bottom, nutrition, sleep hygiene, stress management. And then resilience. Resilience is the ability to bounce back after adversity. And that's something that, really focusing on the stress management and the connectedness piece will improve resilience. And then the warning signs, and this is, I have the little cartoon here for firefighters, but this is true of all people. This comes from the American Association of Suicidology. This cartoon is by Paul Combs. He's a firefighter and he's also a cartoonist, and he's done a whole series of these. And here you have 2 firefighters in the back of the truck on the way to a fire. And one of them is saying, "I've been thinking about suicide, please help." And the caption is, "If only it was this obvious." And so knowing the warning signs is very important. And I've got a couple of slides on this. And my district chief and I have been going around to our department, but also other departments, talking about signs and symptoms, what you can do, how do you talk to people, those sorts of things. And I've also taken 3 of the fire chaplain courses, which has really helped me a lot in learning, how to talk about these things. So is path warm? These are warning signs: ideation and substance abuse. Path is the purposelessness, anxiety, the trapped feeling. Hopelessness is a big one. And then withdrawal, all of a sudden becoming very isolated. Here's where, COVID comes into play. Anger, recklessness, and mood changes. So is path warm? That's just kind of a reminder. So let's talk about a little bit more detail. So if someone is talking about feeling trapped, or they're in unbearable psychological pain, so they can't find a way out of something, or, oh, I don't know what I'm going to do. There is no solution. That's a serious risk right there. The second item, talking about being a burden to others, that's perceived burdensomeness that we talked about earlier. All of a sudden, somebody who's normally pretty even keel starts abusing alcohol or drugs. That's a definite serious risk indicator, particularly if someone is mixing alcohol with other types of drugs. And then someone normally, pretty easygoing starts being very anxious, irritable, agitated, restless behavior, just any type of a change in behavior. So in the fire service, we talk about, so you have somebody who's normally, kind of a class clown, all of a sudden very quiet, withdrawn. That's when the person's officer goes up, "Hey, let's go out and talk about this." And withdrawal or feeling isolated, we've talked about that before. Rage and aggression is another, and anything out of the ordinary in terms of behavior or expressions of emotion can be a tip-off. Humiliation is another really, really big thing. There was a suicide of a female firefighter paramedic a couple of years ago, and she seemingly was being cyber bullied by people in her department, kind of a sexual nature. Again, this is alleged, and she went out into a state park and hanged herself. They found her days later. The reason I mentioned gender is because most, 5% of the fire service is female, so 95% is male. And normally you see a male suicide interviewing the wife who's despondent. I have a clip that I use in the prevention seminars to the fire service where I show the video clip of the husband who is law enforcement, and he's inconsolable being interviewed. He can't even speak. And that really gets to people because of the gender reversal on that one. Seeking revenge. Some people think that, okay, I'll get her, I'll get him, I'll just kill myself. I mean, that's just really bizarre thinking. And there are things that you can say to people when they're going through these things. And in the chaplain courses, we learn, how to assist an individual in crisis. What you want to de-escalate the situation. What are the types of things that you can say to stabilize, de-escalate, and then get the person to the help that he or she needs. Another thing which, calling friends to say goodbye, say, hey, I'm going to be gone for a while, just wanted to say goodbye. Or the last one saying, oh, I'm going to be going on a long trip. Or let's say I figured everything out. I know what I'm going to do with the rest of my life. I've got a plan. That's not good. That could mean that the person has finally devised a plan and has a date in mind and feels this relief. So those are definitely warning signs. And then some of the common myths of suicide. Here's another cartoon by Paul Combs where the firefighter is sinking. The animal is pride, and the sharks are depression, suicide, PTSD, and marital stress. So the number one myth of suicide is that if asking a person if he or she has considered it, it will give the person the idea. That is not true at all. The person has probably been way down that road of thinking. In fact, the person may react with a sense of relief and feel that he or she can actually say something. So that is the number one myth. And psychologists say to actually use the word suicide when you're asking the person, rather than saying, have you considered of harming yourself? They actually say, have you considered suicide? That's what the psychologists say. Another myth, it happens without warning. That is not true. There are almost always signs. We just have to be trained enough or aware enough to be able to notice them. And the third one I've kind of already talked about, but if someone has been having a lot of trouble for a long time, very depressed, and all of a sudden the mood lifts, and most people think, oh, the person's doing well in therapy or the medication is working. Maybe not. Maybe all of a sudden the person has a plan and knows that next Tuesday is the day, has a tremendous sense of relief because his or her pain is finally going to be over. And that's what people are seeing. It's quite common. And then another myth, those who commit suicide are intent on dying. No, they don't want to die. They just can't imagine living another day experiencing the pain that they are having right now. And then the last one about leaving a note, many of suicides do not leave a note. And so if there's not a note, that does not mean that it's not a suicide. And I think I just violated all my grammar rules that I tell my students. And just a few final slides here. When you're talking about what to do, this comes from the International Associations of Chief of Police, and AID Life is another acronym. A, ask. We've already talked about that one. Intervene immediately, take action. Don't walk away from the person. Don't keep it a secret. Find help. Whatever you do, do not leave the person. There's a story that I heard at one of the fire conferences from a psychologist that a firefighter was having, a crisis, needed help. And the lieutenant took the person to see a psychologist. Got the person to the waiting room. The psychologist was out for a minute, I guess the restroom or something. took the person in the office, and then the lieutenant left. That was his mistake. And the psychologist comes back in, goes in his office, comes out and says to the receptionist, I thought there was a firefighter who needed to see me. And right then he heard the sirens. The firefighter had jumped out the 5th floor window waiting for the psychologist. So you never leave the person alone, ever. And I think this is my final slide. I think one of the most important things is ending the stigma. In the fire service, safety officers report directly to the chief. So, and safety officers, if you see something, say something. So that's the same thing about suicidal ideation. Reach out for yourself, someone else, have the difficult conversations. If you ask your friend, hey, are you considering suicide? And the person explodes at you and said, no, I would never do that. You know, a pissed off friend is better than a dead friend. So err on the side of having the conversation. And then there's a term that I learned in the chaplain courses. Suicide is the permanent, or a phrase, suicide is a permanent solution to a temporary problem. And that's something that in our training, we use that to try and frame a permanent reaction to something that can be solved in a different way, and really trying to get the person to think about that. And I think that is my last slide. And so I wanted to open it up for questions, and I will stop sharing at this point so I can see you all.
I have a question about your introduction, Liz, Dr. Fletcher.
Okay.
So what made you, you know, we don't often come across faculty members who are also firefighters. So what, how did that end up happening? How did you make that decision to do both, you know, such different kind of tracks?
Well, I believe it was fall of 2011, and it's when the Tri-County fires, and I have a horse, I board her up there. She was not impacted, but my vet's wife lost her horse in a fire. And I was at a point in my life where I wanted to give back. I make a joke. I knew I could never volunteer for the Humane Society because I'd cry all the time, and I'd have 30 dogs at home. So I wanted to do something, and that incident made me think about it. And then I talked to someone, and I chased down, I didn't even know which volunteer fire department I lived, right? So I got on the website, looked at my territory, and then called and talked to them and asked some questions about, you know, how many women do you have? You know, that kind of thing. And I actually had a sabbatical after being in central administration for a number of years. And that's when I went to fire school. I probably would not have been able to do it had I not been fortunate enough to have that sabbatical.
Wow, that's incredible.
I had a question for Dr. Fletcher. So I was wondering, you mentioned that a lot of college students have anxiety, and this could lead to idealization of suicide and stuff. And so I was kind of wondering, what as a faculty member do you think that you should do in terms of your classes to help reduce that anxiety?
That is a really good question. And that is something that I asked my students in the first assignment. So if you're going to be taking a supply chain course from me, you'll have that question. I think, and I'll just speak for myself. I think that I know a lot more about this than a lot of faculty because I've been studying it. So I would never expect faculty to have, I mean, faculty don't usually have this as their research area unless they're in psychology. I just, because of the fire service angle on the suicide problem, and because I can see other at-risk populations being college students. Having said that, I've always had a rule where I think a lot of faculty are afraid to cross a line between academic and something else. I've always had a rule that if the student opens the door, then that's an invitation. And so I have had students in my office for just talking about school, and they mentioned something about depression or anxiety or ADHD. Once it's out, I can ask them, well, what do you think about that? And I can follow up with some questions. And then I have a list of resources that if the student says, well, I don't know a lot about depression. I say, well, I have a list of resources and websites. Would you like for me to send that to you? And then the student would say, yes, I'll send that. And they usually will come back, you know, in a couple of weeks and say, you know, thank you for that. I'll give you one story. I had a student years ago who was in my office. She'd already taken my class. It was maybe a year later. She's in my office. And she's kind of, her eyes are kind of looking around the room, not focusing. And she was really trying to, think about what she wanted for a career. And I started asking her, well, are you the type of person who could sit at a desk all day? Are you? And I kind of started asking her some questions. What she didn't know it at the time, but I was asking her the inventory of ADHD questions on the self-assessment. And so once she said, well, yeah, that. And so then I followed it up with another one. And then the door that opened, she goes, my brother has ADHD. And to me, okay, bingo, door is open. I said, well, have you ever considered getting diagnosed or getting an assessment? She goes, huh. And then that was into that conversation. And about a year later, she stops by my office, walks in and say, I just wanted to say, thank you. I thought about it. I went and got an assessment. I got diagnosed. I've been getting help and my life has turned around. So I tell that story. That's probably one of my favorites. When I ever beat myself up for, sometimes I feel like I say something wrong or go too far, but I remember that story. And had I not pursued the conversation after I thought the door opened, then, I wouldn't have known that about her.
Dr. Vallier.
Thank you, Dr. Laveau, and thank you, Liz. Dr. Fletcher, that was really, it was sad, but a very important talk. So thank you for that. And just to sort of further support what you've just said, we have really good counselling support, psychological support services here on campus with CAPS. And CAPS offer student organisations and faculty and really anybody who's, anybody who wants it, training to see several of the signs that Dr. Fletcher's already talked about this evening. I remember this coming up in my own training actually about saying the word suicide, which they were very emphatic that we should do. So yeah, it was because I was doing mine with the med school and they were like, really, should we say that? And the psychiatrist was like, yes, he was in our group. So that's very much supported. And my only really other comment, and to sort of ask you if you had a comment about it, was that the work I've done has been mostly in the area of burnout with frontline clinicians, which also is strongly correlated with higher rates of suicide. And so one thing that we know about from that research is that the culture matters, the workplace matters. It's you're not going to be able to have difficult conversations unless you set the stage to have conversations be open on all days, right? You're not suddenly going to be able to start having this like type of intervention for resiliency unless you actually set that ethos more generally within that culture more generally. And so that's a sort of culture of belonging and a culture of feeling respect and having one's dignity supported and that kind of thing. And so that comes up again and again in research that we're doing with residents in particular, who are at that stage in their career where they're not quite able to determine what they're doing every day, but certainly have a lot of responsibilities, especially right now during COVID. Anyway, that was a very long comment. I apologize, but thank you so much.
Yeah, organizational culture is critical. And that's why, for example, in the fire service, if a rookie comes up to the fire chief, or he wouldn't actually, but the rookie goes up to someone in command staff and says, I'm really having a problem with that call. And the person just says, well, hell, why'd you join the fire service? Then you could never have, that just shuts down any conversations. But my chief and the entire command staff are really progressive in, we just got a grant. It's a Department of Justice grant for just under $250,000 flowing through the Texas Governor's Office, which will help us set up a peer support team and also to have licensed professional counselors in the station to learn the culture, because that's been another roadblock to firefighters seeking help. If it takes you 4 sessions to explain to a psychologist what you do, or you tell them what you saw yesterday and they have to excuse themselves to go throw up, then that's not really a good understanding of the culture.
Exactly. Yeah. Thanks.
And I did, Dr. Saria sent over some CAPS resources. So I just put them in the chat for everyone. Just like Dr. Valier said, we have great services, support services on campus. So that is in the chat as well. Other questions?
I had a question. Thank you so much, Liz, for coming and doing this talk. I may have missed it, but maybe you mentioned a theory or explanation, but as you said, the increase in the demand, the need for counseling services on campuses was going up exponentially even before COVID. Mm-hmm. And, you know, it's obvious that the pandemic has created more stress in different ways, and maybe, as you say, it's complicated, but are there theories out there that you've encountered about, let's say, since 2016, why more college students are seeking, these services?
I think there's two reasons. One, I think it goes back to, this generation, kind of grew up with cell phones and technology and different ways of communication, and also isolation because of that. So I think that, I have done a little bit of research on cyberbullying in the schools and cyber suicide, for example. And there's so much bullying in the schools. David's Law is a law that was passed in 2016, and it's named for David Molak, who was an Alamo Heights high school student who died by suicide after being bullied relentlessly over the internet and social media. And his mother, Maureen, set up a family foundation. She goes all over the state and talks. I don't know how she does it. She goes and talks to people. I've met her through the lobbyist who helped get the bill passed. And the bill gives schools teeth to go after these bullies and a variety of other things. So I think that from the high school age all the way into college, the experiences are more horrific. Heck, I've noticed on teaching evaluations, once we went from paper and pencil to online, some of the personal nasty comments that I've had over the years, I would never have put that down in writing on a piece of paper. So I just think there's this anonymity that is allowing this kind of behavior. So, back to your point, I think there is more of this negative types of behavior impacting people. The other side of it, which may be a mixed blessing, I think people are maybe becoming more comfortable talking about it and actually more comfortable reaching out. And that's a good thing, which does increase the demand, but maybe there is more awareness out there. People are, actually talking about it. Again, I go back to my class session that I devoted to that. And I was surprised how much the students talked about it, but also very happy that they felt that they could say those things.
It's kind of interesting on that note with the cyberbullying, and I'm going to call this the silver lining of COVID and quarantine, and the fact that the schools are still, kind of operating, I think, at 50%, and my child is out, and so she's in 8th grade, and she's kind of missing the worst of those out of those 7th and 8th grade years. And so, as much as it's a negative, none of that, all of that is absent from our lives. And so I don't know if, and this is for the students too, you all remember those 7th and 8th grade years. I don't know if it's going to then just wait until high school, but seems like things kind of balance out a little bit by high school. And so some of that cyber, even for college students, I would imagine some of that is missing because of this strange disconnection that we have right now. It also means that we've disconnected in some ways to that kind of bullying. We have other things going on now. I think there might be more of the, I don't know you, and I'm saying all sorts of awful things about you, but not the, I see you around campus, or I see you on the schoolyard, and now I'm saying things about you online. Mm-hmm. So it might, in some ways, and we talk about the emotional impact this is having on our young people. And I do think there might be some positives that we could also kind of, if we could pull them out of here, there are some positives as well.
I wanted to bring back to a specific instance in my psychology class several years ago. Dr. Erbegan, he spoke about CAPS because he's a psychology professor. And at that specific point in time, CAPS services were having considerable backups. I believe it was like days, maybe even a week or so of receiving any kind of counseling services for students. And obviously it's a clear supply chain issue. And do you have a plan or any initiative to kind of speak with your fellow teaching faculty on how to have these conversations with their students, just so the students have more outlets if CAPS services experiences backups?
Actually, and I didn't pay him to ask that question.
That's an excellent.
I've actually been in conversations with one of my colleagues in my department about this very issue and about how we as faculty, and again, I can only speak for myself, but in the past, I've felt very uncomfortable about talking about these things. And that's the first thing that we have to change. And she, my colleague, feels very passionate about this. And so we have decided to kind of start trying to figure out a way to address the issue. We've actually started talking about it with the Bauer honors faculty. You know, we've had a recent meeting, we talked a bit about it. And I think starting that conversation, and then there was I know I'm jumping back, but there was an interesting comment in one of the student papers about what faculty could do. And one of the students said that faculty should be trained in mental health, just that they're required to be trained in CPR. We're not required to know CPR. So I thought that was an interesting misperception. But I think the first step is just starting the conversation with colleagues and to remove the fear factor, if at all possible, because I can speak for all the honors faculty in Bauer. We all care very deeply about students. Dale Rood, who is in the management department, and he won't mind if I say this, he talks about mental health in his management class when he talks about organizational culture. So I think that we can all find, if we can all find ways to kind of have these conversations within the courses, the answer is, you know, how do we do that? And how do we become comfortable with that? So excellent question, thank you.
And I've had students that have actually approached me and said some of what you all are talking about, which I was unaware of the, you know, the trigger, but I have had students approach me and say, don't talk about that triggers me, or that kind of thing. So, you know, I wonder what, you know, how you even approach it, because there is that concern, and that has been brought to my attention, I know, and I think I brought it to Dean Monroe's attention when it came to me.
Mm-hmm. And that's where some of the uncertainty on the part of faculty, you know, how far to go, you know, what to say, what not to say. And it's hard, I mean, it's hard to know perfectly everything about every student in your class. You know, when you start, we don't know everyone's experiences.
I think Brandon's idea is a great one, and I hope you do that and allow us to sign up for that Zoom or that seminar, or maybe face-to-face at some point. I do think that it's necessary. I think it would be really helpful. Any other questions for anyone? Questions?
Hi. Yes, I do have a question. Hi, Dr. Fletcher at Professor level. Dr. Fletcher, I really enjoyed your talk. And so something that really stuck out to me was the issues or the reactions to stress that first responders would deal with, such as alcohol, drugs, abusing alcohol, drugs, risk-taking, reckless behavior, and so forth. And I was wondering if this, to me, that kind of sounds like they might be going through some form of PTSD. And if they were diagnosed with PTSD, would they be recommended to stop being a first responder, or would they be referred to other psychiatrists and just try to work through some of their issues while continuing to help people?
I'll address when you said if you have PTSD, you have to leave the fire service. You might as well just burn it all down because there'd be none of us left. And I say that kind of tongue in cheek. My district chief, with whom I'm doing a lot of training, he has recovered from PTSD. He had to call a mayday. He almost died in a stairwell collapse. He was going through a divorce at the time. He had so much happen to him. He was in the hospital for a while, couldn't work, had so much. And then his best friend was there with him. The friend lived, but then never put on his gear again. He quit the fire service that night. And so my friend climbed back from it, from a drinking problem to getting help. And, you know, here he is, and he and I are talking about PTSD in our talks, and he actually tells the story. PTSD is very common in the fire service, as it is in law enforcement, just like the military. And I think that until we become more comfortable about noticing those things and in ourselves and others, the stigma is getting a little bit better, but it really has to do with the culture of the department and the commitment to this, the PTSD and the depression and the anxiety and the substance abuse and the suicidal ideation, the commitment to be able to address it within the department in a humane way. That's key to the culture.
Great. Any other questions? All right. If there are none, you all can unmute yourselves, and let's give Dr. Fletcher a round of applause. You can take her classes also. She's right here on University of Houston's campus. Thank you so much, Dr. Fletcher.
Thank you very much. I enjoyed talking to you guys. You're a great audience. Thank you.
Thank you.
Thank you, Dr. Fletcher. Everyone have a wonderful evening, and please take note of some of the things that Dr. Fletcher said here tonight. Thank you. Have a great evening.
Thanks.